Trying to learn the vasculitides is probably not worth your time. They're extremely rare conditions that you're probably not going to see on your rotation, and there are so many details that you might get lost trying to prepare for the test. So if you're pushing towards the end of your study period and you don't have the mental bandwidth to commit all this to memory, skip it. But at the same time, if we focus only on the high-yield vasculitides, you might be able to identify patterns that help you on the test. We're going to start off with large, go to medium, then small vessel. I don't want you to pay too much attention to the pathology, and I don't want you to pay too much attention to the words that are used to describe the biopsy because they're really long and you won't remember what it means. Let's start off with some of the large vessel diseases. And there are two: giant cell arteritis and Takayasu's. Giant cell arteritis affects large vessels. And the vessels that normally get picked off are going to be the external carotid, the ophthalmologic artery, and the temporal artery. And you probably learned this disease as temporal arteritis in second year. So going along with those arteries, the patient is going to present with jaw claudication, amaurosis fugax, that is vision changes suggestive of retinal artery occlusion, and with temporal tenderness. Not in time, that is, the temporal artery hurts, hits a headache, and their temple is tender. To make the diagnosis, you get a biopsy. And you're going to see granulomas. But if you see any of these, jaw claudication, vision changes, or temporal tenderness, skip the diagnostic step and simply treat with steroids. This one should be easy to spot. They've got a headache, you poke on the side of their head and it hurts, give them steroids. Takayasu's, also easy to spot. It's large vessels. The artery involved is the aorta and its branches. And we're talking about the subclavian and the femoral arteries that get involved. The patient is going to present with pulselessness. Giant cell arteritis, age greater than 50. Takayasu, age less than 40. Young woman who you can't feel her pulses, radial, brachial, femoral, are not palpable, but otherwise doesn't have any problems, that's Takayasu's. The diagnosis is going to be made with an angiogram. And treatment is with steroids. You'll notice the pattern here of the vasculitides. Steroids is generally the mainstay. Okay, if we move over now and start talking about medium vessel diseases, there's really two that you probably learned about in pathology: polyarteritis nodosum and Kawasaki's disease. I'm going to talk about Kawasaki's but not put it on the board because it's a pediatric disease. Kawasaki's disease is an Asian child or infant that has a discriminating rash on the palms and soles who presents with a myocardial infarction. Medium vessel disease can get into the heart, can cause non-specific stuff on the face. What you're looking for is the rash where the skin is fallen off in an Asian child. They've got Kawasaki's. They need IVIG and aspirin. That's the difference between all these diseases and that one, IVIG and aspirin. It's a kid's disease. So the medium vessel disease that you need to learn here is polyarteritis nodosum. Now the test loves the association with Hep B. Even though most cases of PAN don't have Hep B, if you vaccinate against Hep B, they do better. If you treat Hep B, they do better. But only 10% of the cases are associated with hepatitis B. But if you see hepatitis B and it's a vasculitis question, it's PAN. The patient is going to present with things that don't have a vascular distribution because the arteries that are usually involved are gut, renal, and skin. And that's how you know that it's a medium vessel vasculitis, because it's just, there's not one major artery that can cause this problem. It's kind of all over the place. They're not connected. So what you're going to see in the gut is mesenteric ischemia, and or you'll see renal failure, and you won't know why. And you'll see purpura, or you'll see subcutaneous painful nodules, or you might present with mononeuritis multiplex. What is that? I told you, a lot of words. You're probably not going to remember what they mean. Mononeuritis multiplex means that they have both a motor and sensory deficit in a peripheral nerve that comes and goes. Painful, asymmetric, peripheral nerve, mononeuritis multiplex. So you start putting these things together, but what's probably going to happen is you're either going to have really weird renal failure or mesenteric ischemia, and what you're going to do is get an angiogram, either a CTA or an actual angiogram, and you'll see the aneurysms of the medium vessels. That's how you know you've got PAN. The treatment, not surprisingly, is steroids. But PAN is so severely fatal, you add to it cyclophosphamide. Into the small vessel diseases, we're going to talk about those that are ANCA associated first, and there's one you have to know, Wegener's. Granulomatosis with polyangiitis. I said Wegener's. It's a small vessel disease. The pathology is ANCA associated. The patient is going to present with hemoptysis, hematuria, and something in the nose. Hemoptysis, hematuria, and the nose. Wegener's. You may think that it's Goodpasture's disease because they've got hemoptysis and hematuria, but they're going to mention something about the nasal sinuses, making it Wegener's. The diagnosis is going to be made first by getting a C-ANCA, and then by biopsying some of the tissue that's involved. Generally, that means the lung. And when you diagnose Wegener's, granulomatosis with polyangiitis, the treatment is with steroids. And because this one is so fatal, add cyclophosphamide. In the ANCA bucket are two other diseases. The eosinophilic version of granulomatosis with polyangiitis and microscopic polyangiitis. MP, microscopic polyangiitis, is this with P-ANCA. Eosinophilic granulomatosis with polyangiitis is this with P-ANCA and eosinophilia. Eosinophilic, eosinophilia shouldn't be that hard to figure out. What I want you to commit to memory is Wegener's. Then there's the small vessel disease that's immune complex related. And you're going after two diseases, cryoglobulinemia and Henoch-Schloewein purpura. Cryoglobulinemia has 3 different antibody types, and it's this, that, and blah, blah, blah. What I want you to remember, to keep it simple, hepatitis C, cryoglobulins. What you're going to see in patient presentation for both cryo and Henoch-Schloewein purpura, the immune complex diseases, is purpura. And purpura, that is palpable. Palpable purpura plus hep C. For your test, you've got cryoglobulins. The diagnosis is made by checking for the cryoglobulins. But before you get to cryoglobulinemia, you might see a decreased complement. The treatment is going to be based on how severe the patient is. If they are severe, it's plasmapheresis. You exchange the bad plasma with all the cryoglobulins in it and give it back without any cryoglobulins in it. If you can treat the underlying disease, in particular, if you have hepatitis C, treat the C. If you treat hep C, you're going to treat the cryoglobulinemia. And because there's a pattern to the treatment of all of these disorders, you can use steroids and cyclophosphamide. And once you put it into remission, if you can't treat the underlying disease, you can use some of those other DMARDs like methotrexate and azathioprine. And lastly, henoch-Schönlein purpura, yes, it is supposed to be a childhood disorder, but you can see it in adults. It doesn't have a pathology. The patient is going to present with palpable purpura. And GI symptoms, either pain or a bleed. The diagnosis is made with a biopsy showing leukocytoclastic vasculitis and IgA in the immunofluorescence. Notice I did not write that on the board. If you're thinking it's henoch-Schönlein purpura, take a biopsy of the purpura, get your answer. Treatments with steroids. Okay, I want you to realize that there is way more to vasculitic disease than this. Let's go back over it one at a time, hitting the highlights so you know what you need to know for your test. Loose associations, which are not necessarily true, but will help you get the right answer when a vignette shows up. Giant cell arteritis, headache, tenderness of the temporal artery, give steroids, and then get a biopsy, in that order. Takayasu, less than 40 years old, usually women, no pulses, angiogram steroids. Polyarteritis nodosum, look for hepatitis B in the history, and for a bunch of stuff that doesn't really line up together, find the aneurysms on angiogram, steroids and cyclophosphamide. And notice the switch. As soon as you leave the large vessels, which are treated with steroids, for the most part, you'll be treating with steroids and cyclophosphamide. For Wegener's, granulomatosis with polyangiitis, look for hemoptysis, hematuria, and something about the nose. C-ANCA, biopsy, steroids and cyclophosphamide. Cryoglobulinemia, hep C. Palpable purpura with hep C, get the cryoglobulins. And then depending on how bad it is, the treatment's variable. Henoch-Schönlein purpura, palpable purpura, and GI symptoms. Get a biopsy of the skin, give them steroids. That's what you need to know about the vasculitides.